Hello. I want to talk to you for a few minutes about um, mental health or behavioral health versus physical health policies and structures. Um, so, one of the things that I often say to describe um, this to students is the idea that they're these, for some reason, they're treated as siloed entities. Mental health, physical health, even though research has shown that those are not distinct, um, that mental health affects physical health and physical health affects mental health, and that mental health is also physical health, depending on what it is that you're dealing with. And policy, unfortunately, as much as we're trying to get more to an integrated version of care, um, even with new parity laws, there's still limits to what, um, yes, we cover mental health care, what it stands, what it does, what it stands for. So, for example, I went to the Mental Health America, which is a national organization website. And I'm going to show you that real quick. Okay, so if you look here on the website, I was looking at how are they addressing paying for care. So the idea is that when we're looking at mental health policy, we're really talking about regulation of insurance companies and then regulation of providers, right? You're seeing the same thing in terms of physical health care policy that affects the insurance provider and policy that affects the provider, um, meaning the doctor, the physician, therapist. And for example, policies that might affect both would include things that have to do with discrimination, and so forth. And then, but where the distinction starts to fall apart is, or where the distinction starts to emerge, is where policies define coverage. And you're going to see here that when we're talking about mental health, while there's clear evidence and support for what do you do if you have physical health issues, for example, you will constantly see policymakers say, well, you can go to the emergency room and they have to care for you. Mm-hmm. As long as it truly is something that is threatening to your health, they do. They have to check you. They have to treat you. They have to make sure that you're not going to die. They can still bill you and ruin your credit, but they do have to treat you. Okay. Um, Mental health care is a little different. So, for example, here we are on the national website that's promoting and advocating for change in mental health care. They're directly working on, what do we do in order to advocate for policy? And here they are talking about paying for care. Okay. What do you do when you don't have health coverage? They literally start talking about how to get coverage. That's the focus, how to get coverage. Now you can Google and find organizations that will try to connect you to providers that will provide services for free based on the grants that they get. But they are scarce, far and few in between. And you will definitely see like provider deserts where, yeah, there are some out there, but they might be several hours of a drive away. Okay. Or they might be at capacity for their patients and they can't take anymore. Okay. So these are common occurrences. So the first one is Medicaid, right? And then they talk about Medicare. Then they talk about all these other ways that you can try to get insurance. Okay. Literally, that's the whole focus. And so here's some that talks about free clinics again, but there are provider deserts. There are still potentially fees associated with it. Okay. So why does this matter? Because mental health care in terms of policy is still not recognized as imperative to quality of health and survival as physical health is. Okay. Which has allowed this to become two distinct silos of profession. And where we start to see some integrated care, and here's some more issues, is where it's okay, let's just train nurses and doctors to provide this general mental health care, and we'll just put it all under one window. There are a few that you're starting to see larger organizations where they're like, we're going to have a mental health section, we're going to have a physical health section, and we're going to provide both of these services within the context of this organization. Great. But policy is still greatly divided. I want to give you another example. So first, if we're talking about Medicaid, and that's one of the most common um, insurance providers of those who have limited to no income, okay, which is a large majority of the people that social workers will serve, okay? Um, First, when you go to the Medicaid website to learn about, what's happening, what does this cover? Like 99.99% of the web page is literally going to be talking about physical health, physical health, physical health, physical health. You can Google and say, does it cover mental health services? And it'll go, yes, it covers behavioral health services. And you click on it, and there will be one little statement that says, we cover mental health services. Okay. And it's like, why can't I find what I need to find? Well, there's two reasons for this. One is Medicaid services and what they cover vary according to states. So even though Medicaid is considered a federal program, only part of it is subsidized through the federal government. The rest of it comes through the state. And if you remember, not too long ago, there was a push for the federal government to expand Medicaid services for each of the states, but the states had to opt into it. And there were quite a few states who chose not to. So for example, my home state where I moved from when I came to New York, Tennessee chose not to expand Medicaid services, okay, which affects care. All right, so that's the first thing. Second thing is a lack of transparency allows you to make assumptions about what that means. Okay, so if I was to say to you, yes, of course, I'm going to pay for your mental health services, and that's all I say, then policymakers are less likely to create change that's going to further regulate what I'm doing if they don't like the services I'm actually providing. Okay, so what kind of services are we actually seeing? How can we have these siloed sort of differences in policy and treatment? What does that look like when they're kind of competing against each other? Well, first, it's one pot of money. Okay. So how is Medicaid, for example, going to cover equal amounts of services if they have limited funds that they have access to? Okay, so I want to show you something. One, when you go to the Medicaid website, there's a heavy emphasis on prior authorization. Heavy emphasis. You got to get prior authorization in order to have services paid for. Okay, and they even have it laid out in a time frame. It's very nice and user friendly for providers. Okay, when you go to, and let me pull it up here. Here we go. When you go to if you just Google, let me show you. If you just Google Medicaid health coverage, all right, you can see where it pulls from the Medicaid website. It literally covers inpatient and outpatient hospital services, physician services, laboratory and x-ray services, and home health services, among others. Optional benefits include prescription drugs, case management, physical therapy, and occupational therapy. Okay, it's very clear, okay, what's covered. And because of parity laws, all right, Medicaid, as long as people follow the channels, it's very difficult for them to choose to just stop coverage. There aren't really caps, okay? So as much as you need, that insurance is going to kick in and try to cover. Okay. Now let's do this. Medicaid mental health coverage. All right. So here's what it says. Same website. All right. Tells you a whole lot about, hey, we pay a lot for mental health services. Okay. Um, so it's designed to improve access to mental and substance use disorder services. Okay. Um, so the mental health parity and addiction equity law. Yep, here we go. So it literally just says, generally, behavioral health, mental health, or substance use disorders here. And now they're talking about CHIP. Do you see how it's very vague? All right. It's not listing specific things that it will cover. So what do you end up having to do? You end up having to call providers. Okay. So that's what I did. So remember, this varies according to state. So I called a psychiatric provider in Syracuse, New York, and asked them what Medicaid would cover for mental health services, okay, in terms of therapy. And yes, Medicaid covers mental health, but what they don't say is that there's a cap. So in New York, okay, the state of New York, and this varies across states, it's going to be less in some. I doubt it'll be more in others, maybe Michigan. They're pretty proactive in mental health care for other reasons, but likely not much more than what New York does. The cap is 12. 12 what? 12 visits to a mental health provider. Now, if you're doing therapy and medication management, you get 12 in a year. 12 in a year. At the end of the 12, you have to then go through a process of applying for essentially an allowance to exceed those services and continue care. Okay. And it's just up in the air as to whether or not they're going to do that or not. And your services stop while they're considering it. So 12. So let's think about that for a minute. If you do typical therapy, you're looking at once a week or once every other week, right? So that's going to be either 3 months worth of therapy or potentially 6 months of therapy if you go once every 2 weeks, which most of our clients probably need once a week at least, just because we tend to deal with the severe cases in society. All right, we're not dealing with the worried wealthy. And if we're talking about trauma, that's nowhere near enough. And that doesn't even account for the fact that Medicaid does not pay the same amount as private insurers for those mental health services. So not only is the client getting limited care, but the provider is being paid less for those services as well. It's not like we can just say, this is what we're going to pay. Medicaid says, this is what we will give you. You can choose to accept it or not. And while there is a similar setup within health providers, there's more of a negotiation that goes back and forth. Okay. So that health providers are still profiting when Medicaid covers services. Okay. Because they're able to essentially just set their own rate and say, okay, well, then I'm going to say that I'm going to charge this much more. So if you're only going to give me this percentage, then I've accounted for it and I get my fee anyway. Whereas mental health providers aren't given the same leeway because the policies are treated as if they're these siloed, distinct entities, right? And then you couple that with one provider like Medicaid who has one amount of funds based on each state. where the medical providers can just increase what they would normally charge to get their agreed upon percentage or whatever that is. Then more money is being absorbed on the physical health side, which is draining what's available for the mental health side, right? It's not an endless fund. This is how, because they're functioning distinctly, that they can actually end up competing against each other. It doesn't, it's not talked about that way. Okay. This is just the way that I conceptualize it. And why, for me, it makes perfect sense. Why it's so hard to get more advocacy changes done on the policy that affects mental health. Also, why I'm not a fan of just, let's just let the physical health providers um, take care of the mental health care as well, right? Um, One, because there's different backgrounds and training. Um, but two, is that really going to answer our issues, right? In terms of how do we handle this limited amount of funds when they can essentially charge whatever they want and you're going to give them a percentage of that so they can just adjust that. Say, fine, I'm going to up my rates. Um, so that's essentially what I want to talk about. These two competing entities, these silo, distinct, for some reason, separate things that operate typically underneath one umbrella of a provider, insurance provider, and how saying that, yes, we cover this is actually not what we think that it is. 12 total sessions. If all you did was therapy, you'd get about 3 months out of that. If you're also seeing a psychiatrist for mental health care, you're going to get less than that. It's going to be closer to 2, maybe 1.5, depending on how often you're having to see the psychiatrist. Typically, it's every 3 months to get your prescription refilled. So that's what I really want to make clear to you. Okay. I would encourage you, if you have some time, to Google Medicaid mental health benefits according to your state and see if you can find any more clarity specific to where you live if you live outside of New York. Other things you can do is you can call providers and ask if there are limits, like how many mental health therapy visits can a person have according to Medicaid services, so that you can start to see that while it looks like they're together, they're not. And mental health is treated with limits and caps, and physical health is not. And that's because policy is looking at physical health separate than mental health. All right. So if you have any questions, please feel free to reach out. Thank you for listening. And we'll see you soon.